to our first webinar of 2023. I can't believe last year's whizzed by so fast. I hope you all had a good Christmas and managed to spend time taking some rest from all the hard work that we've all been doing, spending time with family and friends. We've got a good agenda lined up today. If I can just remind everybody to keep themselves on mute unless they're speaking. If you've got any questions, do put them in the chat bar, or you can raise your hand and I'll come to you. And the webinar is being recorded. So, firstly, sad news. We had the sad passing of Dr. Velupillai, who was a former GP working very hard in Newham. And I'd like to just invite Dr. Jim Laurie to say a few words about him.
Yes, thank you. I remember Velu well when I first came to Newham. He was very kind to me, and indeed he phoned me to thank me for doing a urine sampling out of hours shift, because he said that the patient returned where the trimethoprim hadn't worked, which was the recommended antibiotic in that time. And I thought it's so nice he'd taken the trouble to phone me and say that had been useful when the patient had come back and there was the result of the MSU. But he was also very supportive and kind and talked to me about being a Tamil in Sri Lanka. It was just a great joy meeting him. And I had a message from the head of communications at ELT, who used to be a district nurse, and she wrote some lovely words about Dr. Velupillai. She said he was a legend among the district nurses because he often took complex patients that weren't taken on by other GPs. So all of the district nurses had one or two of his patients in our areas. I'll also recall he was especially good at upholding the rights of people with AIDS and fighting their corner for housing, IVF and other issues. And it made me think of the letter that Dame Clare Marks wrote when she stepped down as chair of the GMC just over a year ago when she got pancreatic cancer. And she wrote, as doctors, the interactions we have with our patients are a crucial part of medical care we provide. Our empathy and professionalism shape a patient's experience almost as much as our diagnostic ability or surgical skills, and they shape our own experience as clinicians. So I think that epitomised for me my memories of Dr. Velupillai.
Thanks, Jim, for that. I just want to say one thing. I think, you know, obviously, when our colleagues and former colleagues pass like this, I think, you know, it's fantastic because one of the things that we all talk about is the hard work that doctors like Dr. Velupillai and others have done. But I think one thing that I always think about is, are we looking after ourselves, our own health, our own mental well-being and physical health? So I think we all should just, I know it's sort of New Year's resolutions and everything. I think one thing that all of us should perhaps think about is, are our NHS health checks up to date? Have we had any blood tests that are due? So just look after our own health for ourselves. Is Leila here?
Yes, I am.
Hi Leila, how are you?
I'm okay. Sorry about the background noise. Hopefully it's not too bad.
That's fine. Is Solma with you as well?
Yes, I'm here as well.
Hi, good afternoon. Thanks for joining us. So I'm happy to hand over to you to get our update.
Solma, do you want to start off with the first part and then I'll take over?
Yep, that's fine. Yeah, if you take me to the ARI pathway, yeah, that's the one. Thank you. So mine is a really quick update. So my name's Solma Khatoon. I'm one of the senior transformation managers working across Tower Hamlets, Newham and Waltham Forest. So I've just recently, we've commissioned the ARI service. So initially the ARI service in Newham was only commissioned for a month. We've now extended that service to the 31st of March 2023. So the service is a 10 a.m. to 10 p.m. service. It's currently bookable just by 1-1, but agreement with Paula, practices can start booking into that service now. And the eligibility for the patients is it's 0 to 16 years, so it's for children with suspected strep A, scarlet fever and RSV. All the patients are seen face to face, and the service is based from Vicarage Lane Health Centre. So that's really just a quick update. The service started on the 12th of December, so it'll go on until the 31st of March. Any questions?
Solma, how do practices book into the service? Is it by the normal EMIS cross-organisational route?
So Paul has yet to arrange that. We agreed yesterday for that practices can book in. So just to streamline it across TNW.
Solma, do you want me to come in here?
Yes, please.
We will make them available via cross-organisational booking. There's also the option of either practices or patients contacting our single point of access call centre to book in through that route as well.
Thanks, Paula. And just one other question from that: is there any number in terms of how many per PCN, or is there any limitation on who can book in?
No, the only limitation is around the age range. So it's only children and young people, and it's those that have suspected strep A, scarlet fever or RSV.
Great.
That they are the only restrictions.
Okay. And then I think one of our colleagues is asking for the number for the single point of access. Paula, do you mind just putting that in the chat? I think we do all have posters and things in the surgeries, but if you could share the number, that would be great.
Yep, not a problem.
Thank you.
Any other questions before I pass over to Leila? No.
No other questions for you. Thank you, Solma.
Thank you. Over to you, Leila.
Right, so moving on to polio. First of all, thanks to everybody who's been part of the programme, and we've managed to vaccinate 43% of the eligible children in Newham as of January. So that's a really, really good effort. The programme itself has now been paused for the time being. NHS England are discussing what the phase 2 of the programme might look like. Up until then, practices should carry on vaccinating as normal. There has been an email that's gone out from the central team around how practices should be claiming for the vaccines, but we've just got a summary on the slide after this. So if anybody has any queries or any issues with the claims, just let us know and we'll look into it. The key thing though is to make sure that you've been coding the activity correctly, and we have got a list of codes on these slides which we will share with you after the presentation. Any questions around polio? Okay.
I have one for you, Leila.
Go on.
Sorry. So, you know, when the programme first started, there was a specific cohort that we were asked to vaccinate. And I think it was depending on the age, like the age at a specific start date. So I think it was on their age on the 1st of September. So obviously now we're having new patients, maybe perhaps registering that are new to the country or new to the area. Those are not in that original list. So practices should assume and vaccinate those. If there's any others that are slightly out of the list, should we be vaccinating those? I'm asking because it might be that they were one day younger than the eligible cohort, so they're not included in that original search, so to speak. I don't know if I'm making sense.
Yeah, so we're waiting to see what they're going to say around phase 2, but I think it's by kind of, they are saying that it's now the routine polio vaccines, but it's dependent on what the risks are. So if there is a parent that is out of the range and they're asking for the vaccine, then I think it's just using your assessment. When I say out of the age range, I mean if they've turned 1 since the campaign has started. So I know in central London they have expanded the age range, so they are offering it to children who turned 1 since the campaign has started. But we're hoping the guidance is going to be updated for phase 2 and described, because what we need to know is whether they're going to just class that as part of routine immunisations now, whether they're just going to increase the age range.
Okay, sure. So I think what you're saying is that practices should perhaps wait until we get the phase 2 information before we start vaccinating the slightly out of range children. Okay.
Yeah. If somebody's coming in for their vaccines, or if they're then it's slightly different, but I wouldn't be as the programme is paused, we wouldn't be doing that proactive call recall that we did at the beginning for that cohort.
Okay, thanks.
Okay, and then in terms of the enhanced services, so hopefully you will have all been receiving some communications around the work that's been doing with the what was previously called supplementary network services. There has been discussions at the practice managers forums and with the LMC, but the new offer will be received shortly, and practices will need to just sign and return the signature sheet. There should have been a webinar around it, but if there are any further questions, then please just let us know and we'll pick those up. And then just some general updates. So we are going through a restructure at the moment that's going to help us to understand how we're working as North East London and Place. So we have a new Chief Strategy and Transformation Officer, Joe Moss, who started in October. And Sarah C is the Managing Director now, Primary Care across North East London. So that's how we're operating at the moment. I don't know if anybody's got any other questions, or not just necessarily on anything on this slide, but any general questions. Karen?
I just wonder if Wax is on the call. I'm guessing he might be. That whether Wax, because alongside the structure that you've got here, Leila, there's obviously a provider collaborative activity, and I know that Wax was selected in the run-up to the Christmas holidays to join the board of the primary care collaborative structure, and I don't know, it just seems a brief opportunity for him just to share that news with colleagues.
Yeah, thanks, Karen. So yeah, alongside the ICB, the ICS, there is a set of collaboratives: acute, community, mental health, and primary care. The primary care collaborative essentially is the coming together of provider organisations. It is in the, as it says it on the tin, from primary care, but also Optum, pharma, and dentists. And the SP at the moment is not super clear. We have a strategic meeting, I understand, in the coming weeks to start to think, you know, and build that agenda. My understanding is that the NEL Primary Care Group, which CDs, federations, etc., are invited to, is to continue, and we'll be feeding back from the Primary Care Collaborative to that group. Mark has stepped down from being the clinical lead of the NEL Primary Care Group. Just a reminder, Primary Care Collaborative and NEL Primary Care Group, two separate kind of situations, okay? So they will be, my understanding is a process might have started for recruiting an associate medical director to work with Paul, who will head up, work with Paul and Joe Mars to head up that transformation area, and primary care, NEL Primary Care will be sitting under that, as per the slide that you can see in front of you. So some changes yet to be communicated out via NEL routes. There are 2 GP reps on the NEL Primary Care Collaborative, myself being one, and Sanjoy Kumar from Waltham Forest right now is the second. The first meeting's in is 2 weeks, and happy to feed back on how we're going, and I guess importantly to continue to be a bit of a conduit and work with CDs, PCNs, and the Newham Primary Care Director and other primary care directors to try and connect things up, I would say. So that's kind of the background behind the next stage in terms of primary care. There will be recruitment to the primary care directorates, etc., locally, and that will be happening in the coming months. So some of the architecture is there, and some of the architecture still needs to be put together. But we will try our best to make sure that we keep everybody updated. I know how important it is for practices, PCNs, CDs, Federation to be able to have regular dialogue and contact with primary care commissioners, and all the other things that we're involved in. Right now is Jenny, Leila, Will, Karen, and of course we have support from our borough partnership, which allows us really to chunk things up, right? So something a bit more primary care related will go to those names that I've mentioned earlier. But exciting times, different times, all that on the background of how busy we are, and the challenges that are there for primary care in the media. I don't think GPs are going anywhere, so hoping we can get stuck in together into this next chapter. Thank you.
Thanks, Wax. Anything?
I don't know if Leila and Solma have got anything else to add, actually, but it's just to mention that Jenny unfortunately couldn't join us today, but she's unfortunately leaving later this month. I think she's officially leaving next month, but probably because of annual leave or so, she'll be leaving Newham after quite a number of years locally. I know she's coming to the Practice Council in a couple of weeks, but I've been working with her for some years, and I think really appreciate her effort and her hard work and commitment, and I'm sure all of us do, and I'm sure we all want to kind of send out our thanks to Jenny, who couldn't be with us today, really due to family matters. But she will be here in a couple of weeks at Practice Council. Is that okay, Leila? Is that correct?
Yeah. So I noticed that Greg's put a question in the box around the Newham Primary Care team. So we're not able to recruit to Jenny's vacancy at the moment. So I'll be picking some of that up, and William will be picking that up. In terms of the Newham Primary Care team, there still will be a Newham Primary Care team. What we're just waiting in terms of our structures is how the teams are going to be configured. So we've been working as TNW. Previously, we were working as well, and what's not been agreed is how North East London is going to be carved up. So there will be a Newham Primary Care team, but it's more, we're not sure whether we're going to be working as Newham, Waltham Forest and Redbridge, or whether it's still going to be Newham, Tower Hamlets and Waltham Forest. But your points of contacts within the team should still be the same. but once we see the structures, we'll be able to update further on that.
Thanks.
Is there any other questions for Leila or Solma? No? Okay, thanks, Leila. Thanks, Solma, as well. Right, so I know we've all had in our practices, we have noted the pressures with all the strikes and everything that's been going on. So I think it's really useful to hear from Clare now about the pressures that are in urgent care centre, but also what we've been facing in primary care in our individual practices as well. Thanks, Clare.
Thanks, Alpana. I'm in Nadim's room. You might notice. So can you hear me okay? Yeah. And also my background noise is traffic rather than kids, so it's not quite as much fun as Leila's background. I've been asked to just give an update of what's happening in the urgent care system. So I thought I'd just share with you some 111 data, then some ED UTC activity data, go through the support being provided by practices and NHC, do a quick revisit of the SDEC information, and then just go through the various GPs that are supporting the system at the end. So I don't know if, next slide. Okay, so these are the reports we get to the Urgent Care Working Group, which look a bit of a soup at first glance, but the table on the right is the North East London 111 activity, and the table on the left is the Newham activity. And the graph started, I think the first month is April 2020, when we're in the thick of COVID. And so when you look at the North East London activity, you can see there hasn't been that much change since COVID. So that high volume of calls going through to 111 has pretty well continued. There were 64,000 calls in October last year. If you look at Newham, though, actually it looks like our calls have reduced quite a lot. So that's interesting. And then the table up on the right, that shows where the calls are sent to. But this is well, unfortunately, it isn't Newham. So it's the TNW boroughs. And we know that we all perform a little bit differently. So if we go to the next slide. Yeah, so you can see that 111 calls in October 2020 were 60,000, and now they're 64,000. So you would have thought with all of COVID settled down, everything would have settled down, but it clearly hasn't. What I think is quite interesting, sorry about the noise, is that December last year, of those calls, 45% were deemed to be primary care dispositions, whereas now they're 65%. And I think that just shows the pressure that's going on in primary care, that patients are just trying to access anywhere. And I think their requests from 111 have increased significantly. And also it's quite interesting that the ED dispositions have increased from 9% to 13%. And certainly the information from the hospital is that patients are a lot sicker. That's what everybody's seeing in practice. And I think that sort of confirms it. LES transfers have gone up from 8 to 9%. You think, well, it's just 1%, but actually it's sort of a 10% increase. So there's clearly a lot of pressure in the system there in 111. So if you go to the next slide, is there a, oh yeah, so this is just the numbers. So 2018-19, when we sort of think of that being normal, there were 3,000 attendances a week to Newham. And in December, January 22-23, so just the months now, there are about 1,500 type 1s and 1,350 type 2s on average. So the numbers are about the same, but the pressure is just huge. And for those who aren't aware of type 1, type 2, type 1s are majors and type 1, type 3. Type 3s are minor injuries, wound care, minor illness requiring urgent investigation and support, and urgent primary care. So do we know the rate of conversion to acute urgent appointments, A&E and PC same day? No. Well, you can see that they have the LS transfers on there, but we haven't got the exact numbers. Sorry, Rima. If you go to the next slide. So this gives you a snapshot of what's happening in EDs. You can see that The idea is that everybody should be handed over in 15 minutes. And you can see in April of 2020, so that was around COVID times, there were 10 patients that were having a 30-minute handover, and there are only 2 that were waiting 60 minutes. And if you go through the table, sort of month by month, there have been a few ups and downs, but this just shows you how ED is struggling. I mean, it's unheard of to have all these 60-minute waits. I mean, we all hear about it in the news, but they are really, really struggling. And I think that's what the practices are feeling, because there's the backdraft on the practices. If you talk to ED departments, if you go in them, they say it's the problem with flow. So no matter how quick they are at assessing patients, they get stuck, because you've got patients stuck in the unit because they're trying to offload into hospital beds, and there are patients stuck in hospital beds because they aren't being able to be discharged into the community with the care and social support that's needed to get those discharges done. So that just gives you a feel of the pressure that they're under. I know everybody's under pressure, and we're under pressure as well. So I think it is quite worrying, and I think obviously this is really high profile in the news at the moment. So if we go to the next slide, I just thought we'd look at the support that primary care is giving to the system. And we know that every practice is providing appointments every day to 111, the 1 in 3,000. We know that across Newham there are about 130 appointments a day available to 111, and we know that about 50% of them are being utilised. There has been chatter in the system. I don't know if anybody rings any bells with the waitlist approach. There are 2 practices in the borough that are asked to try a different system, where 111 would just keep on sending the patients as far as I could see. I wasn't quite sure how effective it would be. One of the practices, they seem to be receiving telephone calls. The other practice is offering more 111 appointments and seeing how many can get booked in. I think for large practices, if you just make an appointment available every 2 hours, that's more helpful than bunching up appointments in a particular time during the day, because it's more likely that 111 is going to find a patient that matches that appointment if they're regularly offered. I think for smaller practices, that's more of a challenge, because you have much less appointments to offer every day. So the chance of your appointment being booked is a bit less. In the enhanced access, I know that there are some PCNs where if your enhanced access appointments aren't booked, they can be released to 111. But my observations when we're looking at the sessions is that pretty well all those appointments aren't being booked, which you'd hope, because that's supposed to be supporting practices and primary care. But if they aren't used, they can be released to 111. And then there's been the request to offer additional appointments. So we've tried to add on 2 hours of UTC and 111 bypass appointments at the NHS run hubs, which seems to be really helping 111 with their workload. Next slide. Yeah, so to try and help the system and to try and offload 111 and both UTC, and I think this was the learning which really came from COVID, and also to try and help infection control so UTC didn't get overloaded in the waiting room, turn into a super infection. NHC was asked to provide some extra capacity, and so Glen Road site, Essex Lodge site, and the other practices have all been really helpful in providing space for this work. So we're now providing 17 hours of appointments at Essex Lodge every day during the week, and then there's the weekend service at Glen Road, and then there's also 6 hours of extra appointments that are provided at Essex Lodge and at Glen Road every evening, and then the PCN hubs are offering 111 appointments. So they aren't fully utilised. I think the 111 are more utilised than the UTC, and I think that's a little bit to do with the streaming. I think the streamers seem to be variable, as we all are. Everybody's individual in the way they approach their clinical practice. So some days a lot of appointments used, and some days we have a few more gaps. So that's something we're going to be working with the UTC team on. But certainly that helps take all the primary care, that urgent primary care, out of the UTC, which is giving them a bit more capacity, which is much needed. Next slide. So this is same-day emergency care, and I'm really sorry because when there was that meeting recently, I was doing a clinic, which then I overran, which meant I missed the session. So this poster I have seen in various clinics where I've been doing some sessions. So it seems like it's out there. If it isn't, we can ask Stephanie to circulate again. It was interesting. I went to visit a UTC in Whittington Hospital yesterday, and the concept of same-day emergency care is very variable. So ambulatory care, everybody will recognise, and that's a way that you can get some urgent, non-emergency support for your medical problems. And that's been a really good service at Newham. The bulk of ambulatory care is actually used for following up discharge patients, and I'm not sure primary care uses as much as we could do. But then it is only available until 3 p.m. in my experience, which isn't that helpful. Same-day emergency care is a bit more of a fuzzy concept because it is available at other times during the day by different routes. And there is actually a same-day emergency care unit attached onto the ED at Newham now, which is, I think it's got 3 or 4 beds and a couple of sit-to-fit chairs. And so the idea is that anybody who doesn't need to be admitted or might be admitted, but you can get them processed within 24 hours, that's done by same-day emergency care. If they're going to need more than 24 hours, they get admitted to the acute admissions unit. It is a bit fuzzy. I wasn't there at the presentation, so I think there's lots of ideas on that poster of the types of patients you can send in. There are specifically 12 pathways such as pyelonephritis, cellulitis, PE, etc. But talking to the unit yesterday, as well as to Lisa, anybody they think that they can get processed in the unit within 24 hours, they see as suitable for same-day emergency care because it avoids an admission, which is the benefit. Newham seems to have quite a small unit. I think there are 3 clinic rooms in ambulatory care. And as I said, there are 3 beds in Newham. When at Whittington, they've got a much larger unit and they've got a much smaller, and they're more of a Homerton-sized activity, volume of activity. So there is some work going across Barts because Whipps Cross has a bigger unit, but then they have more elderly care. But their Estec Bay actually has now been converted into a ward because they've got such bed pressures. We did talk earlier, and I'm sure Lisa mentioned it, that we've only got the cover up until 3 p.m. But there is consultant recruitment happening at the moment, and we've heard that they have someone lined up to start probably in the next 3 to 6 months. And we hope then that the service will extend to 8 to 8, at least 5 days a week, if not 7 days a week. We really need GPs to use this service. If you have problems using this service, you need to let us know. You need to get in touch with Lisa or with me or with Paula, or, you know, we have to get the feedback, because if we're not using the service, it's not going to improve. And it's only by people using and feedback and having, you know, double loop, all that type of stuff, you know, it's only with feedback that we can improve the system and we can get them to improve their service and we can understand how better to use it. Next slide. Yeah, so this is just a list of all the GP leadership that's supporting the system. So everyone knows Sabir, who is our medical director, and he is very, very helpful on all the clinical governance and the standards, and has been invaluable as all these services have been developed. Naseem, everybody knows as well, and so he's the lead clinician for the extended access. He's doing pretty well most of it, and he definitely is a night owl. So he really enjoys working late in the evening. And whenever I talk to him and I work alongside him, I'm always yawning and he's always buzzing and just cracking on with work. Shazia, I'm not sure if she's on the call, but we can introduce you if she is. So she has been recruited as the lead GP for the UTC, and she's working at a post that's joint between Newham University Hospital and NHC. And then Mohammed Alim is one of the CDs, and he is the NHC board lead for urgent care. And I think I've just put at the bottom there, all of the GPs are providing leadership, and we really rely on you guys to provide feedback on SDEC, on 111, on UTC, on wound care. And some of you will have seen Anil's messages in the WhatsApp about our wound care service. And that was invaluable because it meant we could actually trace the patient journey, have some conversations that has taken 3 years to have. And we're now starting to get a group together that can actually start to unpick some of this. Because whenever you've got a patient that goes across 4 different services, you know, there's all sorts of messages, and it's like a recipe for things going wrong. So it's only if we can talk to each other and get feedback, it'll help. So the next slide, I think I've got a form. Yeah, so that's the North East London 111 feedback form. And I know a couple of GPs have messaged me about 111 and their frustrations, which we've all had. But I think, you know, people get frustrated with us. So, you know, like I say, it's just communicating, it's sharing the issues, it's identifying what can be changed. 111 really want feedback, because obviously they have a very big service, and if they don't get feedback, it makes it much more difficult for them to make sure that they're providing excellent care and identify the call handlers or the clinicians that aren't quite following pathways or using local services correctly. So I'll maybe ask Steph if she can circulate that after the meeting as well, so everybody can have that in their practice systems. But if everybody needs it, you can just ask me and I'll email it to you. Next slide. So that was some information that was shared at the Primary Care Provider Collaborative. So it's got all sorts of links that practices might find helpful. Just to finish off with, there is a lot of work going on about urgent treatment centres, and there's been the Fuller report, which has sort of established the concept of urgent primary care. And everybody's recognising how important the role of primary care is in the urgent care system, and such that they are looking to have, you know, primary care leadership within UTCs, such as Shazia's position, which has been invaluable. So if Shazi's on the call, I'll just say that, you know, she's been medical director of PELC, she's the clinical lead at Royal Free UTC, she's providing leadership at Queen's UTC, as well as supporting us. And all of that experience is invaluable, because obviously every model is a little bit different, and you want to pick and choose and then find what best fits your local system. So I don't know if Shazia, you're on the call, you can sort of maybe talk through the support that you're providing and NHC is providing to the UTC.
Oh, thank you, Claire. That's very kind of you to say all the things you've said. But it's been a real pleasure to be able to come to Newham, because I grew up in Newham, so it's very personal to me. So yeah, it's a very unique role that I'm in. Obviously, I'm a GP by background, but however, in this context, I'm working across NHC and the Acute Trust. So I work really closely with the ED department and the UTC team. And obviously, being of primary care background and being very closely affiliated with NHC, I think we're bringing kind of those elements together. I think there's always been that slight gap between primary care and urgent care, and into secondary care and into the acute part of ED. So it's been really helpful, I think. And I mean, I've not done a role like this before. I've done lots of roles within a UTC, but actually going out into primary care, having those pathways, having the ability to be able to have that discussion and that development very quickly, it really helps them to have the insight of what's going on within ED and UTC, and having the insight of what's going on in primary care. So yeah, as Claire said, that there is a big drive around primary care-led UTCs. And I think it's really important that we remember that actually it's the same patients, it's our patients that are out being seen in primary care, but also within the urgent care landscape as well. So we're working really hard to kind of work on those pathways out into primary care, using the divert service, using extended access, and then looking at those streaming pathways into UTC, and then looking further to develop to see what kind of developments we can make to improve that patient journey, to improve that patient experience, but also absolutely to make sure that we make those firm links between primary care and the urgent care team. Thanks, Claire. Okay, so there are a few messages in the sidebar, so I've just responded to one. So please do send us examples and cases where there have been issues, because we are developing much more straightforward relationships with the various providers across the service. And I know that Rima and I both give feedback to ELF regarding rapid response. And it's only by giving this feedback back and forth that we can actually tweak and improve the pathways, and just have really open conversations with people saying, you know, if you've got a telephone number, someone needs to answer. If that's not going to work
then let's not share that telephone number, because it just raises expectations. And we all know that when our expectations aren't met, it does create emotional reactions.
Thanks so much, Claire. And thank you for the presentation as well, because I think I actually hadn't realised how many appointments, how many hours of appointments that the hubs are providing to provide, you know, so much extra support to the practices. So thanks for leading on that, and thanks Shazia as well for sort of crossing the bridge between primary and secondary care. Does anybody have any other questions or comments for Claire? No. Okay, and Steph has just shared some information on TeamNet about the resources that are available. And Steph, I think if you could circulate that 111 feedback form, but I think it's worth seeing if we can get it added onto our resource publisher. So then that way it's going to be easier for clinicians to generate the feedback form. It just makes it one step quicker, because I think it is important for us to feed back on 111 service so that we can just improve things. Tammy?
Thanks. Hi, Happy New Year, everyone, if I haven't seen you already. I don't know, I don't want to sound down, but I am, and I think we've got a lot of capacity, but there's never enough. It never seems to be enough. And I just wanted to remind everybody about when we had the last meeting that we talked about the GP alert system, and I'm, you know, going back to your well-being and are we looking after ourselves, Arpna, just to make sure that we also are highlighting to the system, you know, as practices if we're struggling. So please do remember to use that, and to use any way of us flagging that we're at the limit of our capacity. You know, in general practice, we do have a finite capacity. It's not, you know, sort of ongoing, and we do need to take the break. So I just wanted to encourage everybody just to remember that. So whilst we are still, you know, having a lot of capacity, if you look at the data, if we're looking at 111 sending 65% of calls now to primary, to us in general practice, as opposed to 45% sort of 2 years ago, and we've got less of us around, you know, that's a hefty workload. So I just wanted to remind everyone to please do highlight to the system if we as practices are having difficulty. There is you know, we've got to be able to raise our hands just like the hospital does. So remember the GPAS. Thanks.
Thanks, Tammy. So the next item on the agenda is about mental health and our well-being. So can I thank Elise to come and speak to us about Newham Talking Therapies, some of the work that they've been doing and what they're looking to update in the service.
Thank you very much for having me along today. It was great to be here, and yeah, really appreciate you sort of giving me a bit of time just to talk about Newham Talking Therapies. So what I'm going to do is I'm just going to, if we can go to slide 10, Stephanie, and just I won't take you through kind of too much of what we do, because I'm sure you're all aware of it. I'm happy to circulate these slides as well if people want to have a read through them. But this is essentially kind of the structure of how we do things within Newham Talking Therapies, as you're probably aware. And I guess, you know, in terms of how we're trying to expand and I guess try and reach as many people as possible, part of that, what we've been doing is trying to essentially kind of introduce workshops that people can actually attend before they even get to this point of referral and self-referral. So these are kind of the one-off community workshops that people can attend, and basically these are designed for people. So if we can go to that's brilliant, thank you. So these are the wrong dates, ignore these, but I will be able to send the updated ones. But these are basically one-off workshops that people can attend, and they don't actually have to be registered with Newham Talking Therapies. So for example, if you're seeing people that coming through and kind of maybe a bit apprehensive about accessing service, accessing mental health support, you know, they're not really sure, or they maybe don't understand their problems as a mental health difficulty, suggesting something like this can be quite helpful to people to maybe just get the ball rolling with them attending treatment. and also giving them an understanding of what their problems might be within the context of kind of mental health, because often people might not necessarily identify that what they're experiencing is anxiety or depression. They might identify it as, you know, I'm getting really bad headaches, or my stomach, I'm having lots of stomach problems. If we could go to the slide before, this one, yeah, so this is basically just an overview of the community workshops. So we run them remotely, they're very psychoeducational, everything is kept confidential, they're only for an hour at the time, and they're free, and as I say, they're for anyone to attend and sign up. And I guess what I wanted to ask actually as well, as part of this, if any of you guys had heard of them before or were aware of them or promoting them within your practices, or...
So I think most practices, we receive sort of leaflets in the post when there's workshops or posters to put up in our waiting room. And we receive emails as well. So I think there's a mailing list that goes out to practices as well with the details of the workshops there.
Okay. And I guess, do you guys find that there's a lot of uptake, or that you're able to talk about them to people, or?
So I think, you know, the clinicians seeing patients that might be suitable for the workshops would signpost them to that. But I think we may not necessarily know if a patient has attended, because we don't really we wouldn't necessarily get a clinic letter or any correspondence to say that your patient has attended. But I think it is variable from practice to practice. But I think it might be worth working with the PPG to see if they can share that with the patients. Because I think a lot of these types of workshops, the patients would sort of go themselves to it, wouldn't necessarily warrant a referral from the GP or somebody else at the surgery.
Does
so
look
more
like
about
our
patient
partner.
empowerment.
Yeah, I was just going to say, it does look like in the chat that a couple of key colleagues in Liberty Bridge and Market Street haven't awareness of them. So maybe that isn't as comprehensive as...
Yeah, because I think that's the thing is, I guess what I was thinking is maybe people might be aware of Newham Talking Therapies as a service that they can obviously signpost people to. But I guess the good thing about the workshop is it doesn't need a referral. The person, as I say, might be a bit ambivalent about whether they want to even address it as a mental health difficulty. So even just sort of putting their toe in the water can be quite helpful. Yeah, so I guess that was kind of one of the main points that I did want to cover today in terms of the new things that we're doing. I did have as well, I don't know if the person is here who gave some feedback, but I did get some feedback as well about secondary care referrals after treatment with us. And I wondered if the person was here and wanted to expand on that, or I can obviously go over.
I think it's Dr. Farouk, Elise. I don't know if Dr. Farouk's still with us, because I know he's got to head off shortly, but Nadeem, I don't know if you're still here. Anil's got his hand up as well.
Oh, hi, Karen. I can probably pick up for Dr. Nadeem Farouk. Elise, it was just, we had a conversation about patients get referred to yourselves and Talking Therapies, and you do a great job. But when it doesn't meet the threshold, you send it back to primary care. And whether there's an extra link that you guys could have with ELFT, which is the mental health provider, because there's no point that patient coming back to us in primary care, because all we're going to do is put in another form, waste an appointment, and send it over to ELFT when you've already got all the information. And your practitioners give a really good summary and give a real good analysis of what the issue is. So literally all we do is copy and paste what's on that letter onto a referral form. Patient sits with us for 10 minutes and then we send it off again. So whether we can develop that new pathway, so it will really help access for primary care too.
So is this people who, sorry, don't meet the threshold in terms of that they're not, that their needs are too high and they need sort of more secondary care? Yeah, okay.
Because as we sometimes don't know what level that patient help they need. So Talking Therapies covers a huge amount of those patients, but there's a few patients which need extra care. And once your practitioner has spoken for them, because you guys get half an hour to an hour to talk to them, we get 6 or 7 minutes. So we don't really get to capture their issues. But your summaries are brilliant. So whether you can work with ELFT and just allow your team to do a direct referral.
Yeah, I guess that's interesting because I mean, that would normally be the procedure in terms of doing those direct referrals.
At least just to come in, I think it's variable. So I've had some patients where they've been seen, and the person that they've seen as part of the Newham Talking Therapy service has referred them on, and then there's others where they get referred back to the GP. So is it maybe a case of who they're being seen by? Is it maybe a psychological well-being practitioner is not able to make the referral, whereas a high intensity CBT therapist is?
No, they should. Yeah, they are all able to. The only thing I can think of what's happening is that maybe they're being. The only thing I'm thinking is it when they're being screened for initial assessment, and maybe being deemed not suitable, and then being sent back to you to refer to secondary care, if that makes sense, because we do sort of like a pre-screening before people have an assessment. And if there's information to suggest that there's a kind of an axis 2 disorder that we don't treat, severity, longevity, that kind of thing, what we would do is we would maybe say this needs to be sent to secondary care. So that's the only reason I'm thinking maybe that's happening. But maybe I need to take back to the service and kind of figure out, because I guess, yeah, that's not ideal, is it, if all the information's kind of already there, and it sort of cuts out the middleman, doesn't it?
Yeah, and I think the other thing is with regards to medication. So I think if we're looking at how we can improve the service for the service user, I think sometimes patients may be seen by a therapist and they may be thought to be benefit from an SSRI or something of that sort, but they're referred back to the GP. So there's that delay where the patient, we don't always get the letter straight away. So the patient might ring up to say that, oh, I've been told I need medicine, but there's no letter on the system. And so I think the other thing to look at is that, can we work out, is there a clinician that you could have that does the prescribing from your end, or is there a more efficient way of getting that correspondence to primary care? Because a lot of the time we get the letter at the end of their set of sessions.
Okay, right, yeah. Yeah, okay, that's interesting, yeah. Because I guess, in terms of neither the PWPs nor the high have ability to prescribe. So I guess that's a tricky thing, is that, yeah. Okay, well, I mean, it's something that I can definitely take back in terms of, because I suppose it sounds like what you're saying is you get the information sort of after the fact, essentially.
Basically, yeah.
Yeah, okay.
Tammy?
Thanks. Just to follow up on that point, we're not necessarily asking you to prescribe even, but just to even give them a note to say that that's what you're suggesting, so that at least we've got some communication there and then with the patient. So that would be really helpful. Just to say, I seem to be one of the lucky people who is on the list, and I do get notification of the workshops, but I think that's probably more from the diabetes space, because we do speak about this quite a lot. So I think for me, it's listening that there's obviously an issue with where the comms are going out to, and I just wondered, are you in touch with all of the sort of the community and the faith organisations? Are you pushing that, the offer of the workshops through those routes? Because there are a lot of people who we will not be seeing in primary care, and certainly not us as the GPs. So I think as we're now this new sort of place-based partnership, it'd be really quite helpful to have those lines of communication in place so that we know where to signpost people. So we've had public health come and talk to us about Joy software. We've got, sort of all of these other sort of, Newham magazine or whatever that goes out to patients' homes, or, taking an advert out in the local newspaper, the Newham Recorder or whatever. It's just, what else are you doing? Because you're not going to get a huge amount of attendance if you're solely relying on us as GPs to be spreading the word. So that might be just worth looking at what you're doing comms wise. And obviously there's a comms and engagement team in lots of different services, from commissioners to us as LMC. So it may just be worth making the links as you've done today with NHC.
Yeah, because I did see in the chat someone mentioned about Newham magazine. I'm not sure.
That's posted through every residence. It basically goes to every resident. So I think that's one thing. Also Newham Recorder, but that might be a bit more difficult. Elise, Stephanie, our comms from our comms team at NHC has kindly offered to work with you with regards to this, because I think she has some experience in working in comms for another talking therapy service. So I think that would be a good first point of contact.
Yeah, definitely. I saw your so we do have some contacts within LBN, but maybe not necessarily the right ones to get us in the right places. So yeah, any help that we're all wanting the same aim here, aren't we? So maybe I could follow up with that afterwards as well.
Yeah, and then Hazel's also made a suggestion about the Practice Managers Forum and putting it on Practice website. So I think, NHC also has a newsletter. So there's lots of places where you're able to share the information with regards to these workshops and any other thing that you think might be relevant.
Okay, so I think it's just making those links, I suppose, really, isn't it? Who would be the best person, do you think, for me to follow up with in order to
I think if you meet with Stephanie, if that's all right,
yeah,
then I think we can take it from there.
Okay.
Yeah, I was going to say definitely. Elise, let's speak after this meeting sometime.
Yeah, we'll get a meeting together, because I think that would be great. Because I mean, we do have sort of like quarterly posters that we can send out with all of the dates and times and the topics we're covering and stuff, which I think some people are receiving, maybe not others. So yeah, yeah, okay. Yeah, I mean, I don't know if anyone has any questions about the workshops or anything. I know I don't have a lot of time, so I don't want to go on too much, but yeah, did anybody else have any questions just generally about talking therapies or the workshops? Hopefully that means I've covered everything. Yeah, I think yeah, I mean, I guess that was the main point that I wanted to sort of get across today by coming in, is just kind of, I guess, checking if people were aware of it and how we can make that more of a yeah, I don't think we need the rest of the slides. I think that's okay.
So I think in terms of, what would be useful, and I think we've already covered it, but just to summarize, I think if you could look at the prescribing side, if there are any recommendations for any prescriptions to be done, how we can work around that, and also perhaps a pathway about, or clarifying the pathway with regards to onward referrals or rejecting a talking therapy assessment because something else may be a bit more appropriate. So I think those are the two things that I think the clinicians would really appreciate.
Yeah, because I suppose my understanding of it is the same as it's the same as kind of safeguarding. If someone becomes unsuitable for primary care within our service, then it's, my understanding is, it's down to us to make that referral, which makes sense. So I guess that's the thing that we need to clarify. As I said, the only reason I can think of that would be happening is it's happening at the pre-screening stage. And actually, just from looking at their notes on Rio, for example, we've deemed that this client's not going to be able to be offered treatment by us. But I don't, yeah, maybe I can go back and maybe update you on that.
Okay. Thank you. And just one other thing, I know in the past Talking Therapies used to run workshops and some sort of support groups and things for healthcare professionals. If that's still going on, if you could share that as well for colleagues, if there is something like that going on, that would be good.
Yeah, so I mean, I mean, as I say, anyone is welcome to come to any of the workshops. So you obviously but we can put on kind of bespoke workshops if you think that would be appropriate for managing sort of stress and things like that. Specifically for you guys, if you need that. So I don't know if that would be something that would be of interest that I can speak to someone about. And we're quite flexible in terms of what we can offer. But obviously, yeah, those workshops that we run sort of generally are open to anyone if they wanted to attend. But I appreciate that there may be some difficulties with that if you don't know who's going to be attending and things like that. So, but we can obviously do those bespoke ones for you if that would be of interest.
Okay, great. Thank you. Thanks so much. I think there's a few comments that might be worth looking at in terms of contacts for yourself from other teams in the chat bar. Elise.
I can see, brilliant. I will jot those all down and follow up with them. So thank you very much for having me, and thank you for being so helpful with all the comments and contacts as well.
Okay, great, thank you. Okay, so I hope colleagues found that useful. Right, so NHC sent out a GP practice survey last year now, and one of the questions was, would you like to be put into our prize draw? So I think some of us have replied back to that. So the prize was a tablet, and we are going to announce the winner right now. So Stephanie, you may need to help me with this.
It should be doing it now.
Okay.
Can everyone see the wheel?
Oh, there we go. Every name that entered and said they were happy to be included was put on the wheel. And it looks like...
So it's Pooja. Well done, Pooja. Is Pooja here? No.
Second place wins then. Second place wins. Who's the closest?
We will be in touch with Pooja and get a when we say a tablet, we're meaning computer, not medical.
I think like an iPad tablet. Okay, and thanks NHC for doing that. And also with regards to the practice survey, I think it is useful for everybody to feed back to NHC, because we're always, we are trying to be responsive. There's lots of support that's available and lots of services that we're trying to improve. So do feed back to us. Stephanie sends out a fortnightly newsletter that has lots of useful information in there. But if you think that there's something else that you'd like to be added, just do feed back to us. Just lastly, one other thing that I wanted to mention that is practices should have all received a bit of a sweet treat from NHC. I've got mine here that I'm going to feast on with the team later on this afternoon. So it was just really a thank you from NHC just for all the support that the practices have given us in order to become a KIC. You should have all received the share certificate with the sweet treat as well. And please do take pictures with the teams and do share them with us so that we can post them on social media. That would be good fun. We've got a launch event at the Vicarage Lane offices on the 22nd of February that you should have all received an invite to. So please do come and join us for that. Karen and the rest of the board and the team will be there, and we'd be happy to see you all. And if there's anything else that you want to know or anything, that you want to share with us on that day, please do come and join us. And if not, it will just be a nice celebration of us becoming a KIC. Right, thank you. Right, so if there's no other comments or nothing from anybody else, we finished a bit early today. So happy weekend, everybody, and we'll see you at the next webinar. Oh, just one hand up, Dr. CN.
Hello, happy new year to everybody. I have a few comments and I was waiting that whether you have a time so I can tell you, otherwise I miss it. First thing, in practice, we, all the time patient use practice number. Now I think we are somewhere confusing the patient to use 111 or other numbers, to ring for. And many times you find that patient in the daytime surgery is open and they have rung 111. Now the patient doesn't know that patient will be bounced back. So that is the one thing. The second thing, AE attendance. Our colleague has worked very well and produced the data, but I feel there's one thing missing in attendances. There is no mention of any staff, that whether the staff is a consultant staff, staff is a trainee staff, staff is a locum staff, and whether the staffs are increasing or decreasing. Now, if you don't have that equation, we are not going to tell the government that there are not enough doctors. All right, and we are using agency staff. So I think this is just nudging, is not a criticism. This is just nudging for the improvement, that we should include this. So we let the government know. Now what happens? The polls tell me that, oh, there are 5,000 doctors are not there. I mean, we should be knowing that there are not enough doctors, there are not enough GPs, there are not enough trainee, and we are using agency staff, we are using agency nurse staff. We're waiting for somebody else to do it. Why can't we do it? Why can't we just include that data that there are not enough staffs in the hospital to work? All right, is not our fault. It's not our fault. But we should point it out. If we don't point it out, who is going to point out? The last one, we know Sarah C. She has worked in Newham, so it will be nice if somebody present us, and we can talk to her, we can meet to her. Thank you.
Thanks, Dr. CM. So I think what you've made some valid points there. I think perhaps it might be worth you having a conversation with Clare, or I think if Clare's still here, Clare, if you could just take note of those comments. And I think in due course, I think we will meet Sarah C again. I remember she was one of the people when I first started that helped me set up my registration and my performers list just over 10 years ago. Right, anything else from anybody else?
Arpana, I was just going to say, Dr. CM, you're absolutely right in that the hospital at the moment, they're really struggling with staffing in the same way as I think we see in primary care. So, I mean, Clare and Shazia are closer to the detail, but I do know they are surviving on a lot of locum staff and a lot of temporary staff. So I do think that whole issue of how and what we can do around security of tenure and bringing greater opportunity for staff to stay with us, both in the primary care space and then obviously from the Newham Hospital. And I think there's some real thought going on across Newham around workforce development and around supporting our staff to have that strength of connection. It's not an easy answer, but I think there is some thinking going on, but certainly the points are very well made.
Thank you, Karen. Okay, on that note, happy weekend, everybody. I hope you all managed to get some rest, and we'll see you at the next webinar. Okay, thank you. Bye.